Alzheimer's is a disease that steals memories, relationships, and ultimately life itself. But in 2025, a wave of hope is surging through the research community. This video explores the most promising advancements that are giving millions of people affected by Alzheimer's a reason to believe in a brighter future.
Welcome to the deep dive. Today, we're tackling a really important topic, one that affects so many people: Alzheimer's disease.
It really does.
We've gathered, a lot of the latest info stats, research findings to really dig into what's happening right now in 2025, and importantly, why there's this growing sense of, hope.
It's such a critical area, and the challenges are absolutely significant. They haven't gone away, but the progress we're seeing now, it's giving us new tools, new understanding. It feels different.
Absolutely. But before we dive into the hopeful side, we really need to grasp the scale of this.
Yeah.
What's the current picture? How widespread is Alzheimer's right now?
Well, the numbers are pretty sobering. The latest estimates suggest around 7.2 million Americans age 65 and older are living with Alzheimer's dementia today. 7.2 million.
Yeah.
And that number isn't staying put, is it?
Unfortunately not. If we don't see some major medical breakthroughs, the projections show that number could almost double.
Double.
Yeah, potentially hitting 13.8 million by 2060. That kind of growth really highlights why the research is so urgent.
It certainly puts the pressure on. Yeah. And mortality figures also tell a stark story.
They do. Alzheimer's is a major cause of death. It ranked 7th in 2022. And it looks like it'll probably be back up to 6th place once the final 2023 data comes in.
Okay.
But what's really striking, if you look at the trend over time, reported deaths from Alzheimer's jumped dramatically. Over 142% increase between 2000 and 2022.
Wow, 142%.
Yeah, and during that same time, deaths from other major killers like stroke, heart disease, even HIV, they actually decreased.
So Alzheimer's is really bucking the trend there.
It really is. It underscores the unique challenge we're facing with this disease.
And it's not just the individual diagnosed, is it? The ripple effect on families, on caregivers, it's enormous.
Oh, immense. It's a huge societal cost, but so much of it falls on individuals, on families. Estimates for 2024 suggest nearly 12 million family members and other unpaid caregivers provided something like 19.2 billion hours of care.
Billion. With a B.
Billion. And if you try to put a dollar value on that, it's estimated around $413.5 billion. Staggering.
That's an incredible amount of support happening outside the formal healthcare system. And I recall seeing something that even though the total number of these unpaid caregivers might have dipped slightly,
That's right.
the amount of care each remaining caregiver is providing has actually gone up.
Exactly. Those who are caregiving are doing more, owning a heavier load, and the toll on their own health, their well-being, it's significant. We see increased risks for emotional distress, mental and physical health problems.
Yeah.
I mean, research shows dementia caregivers get, on average, somewhere between 2.4 and 3.5 fewer hours of sleep per week.
Per week, wow.
Yeah, compared to non-caregivers. Think about that adding up over time. It's incredibly draining.
It paints a really tough picture. And then beyond the family caregivers, you have the professional side, the paid workforce. There are challenges there too, right? Big ones.
Absolutely. We're facing shortages across the board in paid dementia care, in healthcare settings, in community-based services. Take geriatricians, for example.
Doctors specializing in older adults.
Right. In 2021, we only had about 7,000 practicing in the whole country. But fast forward to 2050, just to care for the projected number of people over 65 with Alzheimer's dementia, we'd need over 18,000.
That's a huge gap.
A massive gap. And that's not even counting the 30% of older adults who have complex medical issues alongside dementia. Plus, the shortage isn't uniform. Some states are facing much more critical situations than others.
And what about the direct care workers? The people providing hands-on care day in, day out.
They're absolutely crucial. I mean, they enable people to stay at home longer, they help avoid hospital trips, they're often the first ones to notice subtle changes.
Right, because they're there constantly.
Exactly, but the reality is they face persistently low wages. The median was around $16.72 an hour in 2023. That's roughly $25,000 a year.
That's really low for such vital work.
It is, and these conditions often stem from, deeper structural inequities. This workforce is disproportionately women, disproportionately people of color, and yet the demand is exploding. Most states need double-digit percentage increases by 2032. 11 states need over 30% more direct care workers. It's a workforce under incredible strain.
So, growing numbers affected, huge caregiver burden, workforce struggles. But this almost translates into massive economic costs, too.
It definitely does. The financial impact is enormous. For 2025, the estimate for total payments, so healthcare, long-term care, hospice for people 65 plus with dementia, it's projected at $384 billion.
Billion, again. And that doesn't even count the unpaid care value we just talked about.
Correct. That $413 billion in unpaid care is on top of the $384 billion in direct costs.
So who's footing that $384 billion bill, mostly?
Well, Medicare and Medicaid cover the biggest chunk, about 64% combined. But out-of-pocket spending by individuals and families is still substantial. It's estimated at $97 billion.
That's 25%, a quarter of the total cost coming directly out of people's pockets.
Exactly. So it's really no surprise that anxiety about affording long-term care is so widespread.
Yeah, I can see why, even for families who might seem financially comfortable.
That's what the data shows. The potential cost of nursing homes, assisted living, it's a major worry for a lot of Americans across income levels.
Okay, so we've laid out the SOAP. It's a huge challenge, personal, societal, economic, but this is where things start to shift. The reason for that wave of hope we mentioned at the start, it's the science. Let's dig into the biology, what we understand now.
Right. So fundamentally, Alzheimer's is the most common cause of dementia, maybe 60-80% of cases. But it's also important that it often doesn't happen in isolation. You often see what's called mixed pathologies, other brain changes happening alongside it. The classic hallmarks, though, are beta amyloid plaques, these abnormal protein clumps outside the neurons, and then tau tangles, which are twisted protein strands inside the neurons.
Plaques and tangles. We hear those terms a lot.
Exactly. And ultimately, these lead to the neurons not working properly, dying off, and damage to the brain tissue itself.
And the really crucial insight recently, it seems, is when this process starts. It's not right when symptoms appear, is it?
Not at all. That's a huge shift in understanding. Biomarker studies test that can detect these amyloid or tau proteins or other signs of brain change, they show. These processes can begin years, even decades, before someone has noticeable memory problems.
Like decades.
In some studies, particularly looking at genetic forms, they've detected abnormal amyloid levels up to 22 years before symptoms were expected. This long period before symptoms is what we call the preclinical stage.
And that preclinical stage is a key target now.
Absolutely. It's a massive focus for research into prevention and early intervention.
So, if the disease starts so early, finding it early becomes critical if you want to actually, intervene effectively. How's diagnosis changing to make that possible?
Well, traditionally, diagnosis relied on, putting pieces together, medical history, cognitive tests, neurological exams. There wasn't one single definitive test for a living person, which made it tricky, especially in the very early stages.
Right.
But these new biomarkers, especially the blood tests we're seeing develop, they are looking like potential game changers.
Absolutely.
Recent studies are really highlighting this. Adding a blood test that detects Alzheimer's biomarkers, specific forms of amyloid or tau, can significantly boost diagnostic accuracy. One study in primary care settings, which is where most people first go, it showed accuracy jumping from about 61% with the standard approach to 91% when they included a blood test.
That's a massive difference, 61 to 91%.
Huge, especially in that frontline setting. And that accuracy helps us identify people much earlier, potentially even in that preclinical stage we talked about.
So finding the underlying pathology even before major symptoms.
Exactly. Even when cognitive symptoms are minimal or maybe not even there yet. And looking at the big picture, estimates suggest that right now, in 2025, somewhere between 10 and 12 million older Americans likely have these Alzheimer's brain changes and some level of cognitive impairment. That includes mild cognitive impairment, or MCI.
And MCI is what exactly?
MCI involves noticeable, subtle changes in memory or thinking, but they're not severe enough to really interfere with daily activities. It can be, though, a stage that precedes dementia for some people.
Okay. And what about when someone just feels like something's off with their memory, even if tests are normal? Subjective cognitive decline.
Yes, subjective cognitive decline, or SCD. That's precisely it. The person feels their memory or thinking is worse. But objective tests don't pick it up yet. Now, not everyone with SCD develops dementia, but for some, it is an early warning sign.
It's worth paying attention to.
Definitely. It's often the trigger for someone to talk to their doctor. And importantly, that feeling might be caused by something else entirely. Sleep problems, depression, medication side effects, things that can be treated.
But are people acting on that feeling? Do they go see a doctor?
Well, that's a bit of a gap. Data suggests only about 46% of people 45 and older who report experiencing SCD actually talk to a healthcare professional about it.
So there's still some reluctance or maybe lack of awareness there. But overall, it sounds like people do want to know early if they have Alzheimer's.
Oh, yes. Survey data is pretty clear on that. About half of Americans say they'd want to know even before symptoms showed up. Another 29% would want to know with just minor symptoms.
Why? What are the reasons they give?
The main reasons are practical and personal, getting financial and legal affairs sorted, making future care preferences clear, giving family time to plan, and critically, having the chance to access potential treatments or join clinical trials.
Of course, there are worries too, right?
Understandably, concerns about insurance, test accuracy, the emotional impact, the cost. Those are all real factors people consider.
Okay, let's pivot to treatments then. For a long time, it was mainly about managing symptoms, right? What's the landscape look like now in 2025?
Yeah, the symptomatic treatments, drugs like cholinesterase inhibitors, memantine, they're still very important. They help manage cognitive and behavioral symptoms in mild to severe stages. But the huge shift, the real news, is the arrival of disease-modifying therapies.
These are the anti-amyloid drugs we've started hearing so much about.
Exactly. Therapies designed to target the underlying biology, the amyloid plaques. We now have FDA-approved drugs like lecanemab and donanemab. These are monoclonal antibodies. Basically, they bind to amyloid and help the body clear it from the brain.
And do they work? What do the trials show?
The trials showed they can moderately to significantly slow down the rate of cognitive and functional decline. But, and this is crucial, it's in people with mild cognitive impairment or mild dementia who also have confirmed amyloid pathology.
So they slow things down, which is huge, but they don't stop or reverse the disease. They're not cures.
That's absolutely right. It's a critical distinction. They offer a meaningful slowing for the right patients, carefully selected patients, but they are not cures. And they aren't suitable for everyone with Alzheimer's. Patient selection is key.
Okay. But it feels like a major door has opened. Is the drug pipeline looking more promising now?
It really is. It's much more robust in 2025. We're seeing dozens of drugs in phase 1, phase 2 trials, exploring a whole range of different approaches. Not just new drugs designed specifically for Alzheimer's, but also looking at repurposing drugs already approved for other things, which can sometimes speed things up.
It's not all just about amyloid anymore.
No, definitely not. While amyloid is still a major focus, the field has broadened. There's a lot of research targeting tau pathology, neuroinflammation, problems with synapses, other key parts of the disease process.
So the future might be combination therapies, like we see in cancer or HIV.
That's certainly the long-term vision many researchers have, using a cocktail of drugs that hit different targets. But, we need the trials first to prove that combinations are safe and more effective than single drugs. We're not quite there yet.
And how are these new amyloid drugs actually given? Is it simple?
Well, the ones currently approved, lecanemab and donanemab, are given by intravenous infusion.
So IV drips.
Right. Usually every couple of weeks or once a month. That means regular visits to an infusion center or clinic. Some drugs in trials, like rimternetug, are being tested as subcutaneous injections, like a shot under the skin. That might be quicker per visit, but still requires regular administration.
Okay, so there's a commitment involved. Now, beyond drugs, what about non-drug approaches? Lifestyle things, other interventions?
Yeah, this is another really active area. The sources consistently point to several factors linked to better cognitive health, though, pinning down causality specifically for Alzheimer's versus general dementia risk is ongoing work. But things like cognitive activity.
Keeping the brain busy, like puzzles, learning new things.
Exactly. Learning a new skill, reading challenging material, playing strategy games. Studies associate these kinds of activities with a lower risk of MCI and dementia.
And sleep. You mentioned caregiver sleep loss.
Yeah.
Is our own sleep important for our brains?
It seems incredibly important. There's growing evidence about the brain's cleaning system, the glymphatic system.
Right, the cleanup crew.
Yeah. During deep sleep, cerebrospinal fluid flow increases and helps flush out waste products, including beta amyloid. Poor sleep might hamper that process. It might even be a two-way street where Alzheimer's pathology itself disrupts sleep. So focusing on good sleep quality seems really key.
Makes sense. Avoiding head injuries, that seems obvious.
Yes. Avoiding moderate or severe traumatic brain injury, TBI, is definitely a factor, though often the dementia that follows TBI is due to the injury itself, not necessarily Alzheimer's pathology. Protecting your hearing and treating hearing loss are also mentioned as potentially modifiable risks.
What about things like social life, purpose?
Those come up again and again. Strong social connections, having a sense of purpose. Research suggests these have really powerful positive effects on health overall, including brain health and potentially longevity.
Okay, now There was some really fascinating specific research mentioned in the sources, something about ketones and diet.
Yes, there's ongoing interest there. Studies in mice and some human trials, too, have looked at ketogenic diets or supplements that induce ketosis. The idea is that ketones might offer an alternative fuel source for the brain when glucose metabolism is impaired, or maybe have other protective effects. The exact mechanisms are still being explored.
Interesting. And then tied to that glymphatic cleanup crew, this research using light and sound, that sounded pretty futuristic.
It's definitely one of the most cutting-edge, non-invasive approaches. Remember how that waste clearance happens mainly during sleep? Well, this new research, really highlighted in 2025, suggests you might be able to boost that process using external stimuli. Specifically, flickering light at certain frequencies, like gamma frequency, around 40 hertz.
So flashing lights could help wash the brain.
That's the theory they're testing. The idea is that stimulating neurons at specific frequencies might help synchronize brain activity in a way that promotes the flow of that cerebrospinal fluid, helping to clear out waste, like amyloid.
Wow.
Studies in mice and humans are looking into this. Even simple things like deep breathing have been noted as potentially boosting CSF flow slightly in some research. But the big news is a large ongoing phase 3 trial called HOPE-B. It's testing a non-invasive flickering light device, specifically in people with moderate Alzheimer's symptoms.
Moderate. That's interesting because so many trials focus on early stages.
Exactly. And the HOPE trial is still recruiting, which is significant for people in that stage who might have fewer trial options.
That's really promising a potentially non-invasive, accessible approach.
Okay.
Shifting gears slightly.
Yeah.
How is care actually delivered right now? And how does it need to change?
Well, the current system is often described as siloed. Healthcare, long-term care, social supports, they often don't talk to each other effectively.
Fragmented.
Very fragmented, which makes it incredibly difficult for people with dementia and their families to navigate everything and get the support they need.
So the push is towards more integrated models.
Absolutely. The goal is a collaborative workforce where different professionals, doctors, nurses, social workers, care coordinators, direct care staff work together seamlessly. This kind of integrated approach can help catch problems earlier, lead to better care plans, provide much better support for caregivers, and just make more efficient use of resources.
Are we seeing examples where this is actually working?
Yes, thankfully. The sources mentioned several initiatives. There's the NIA Impact Collaboratory, which tests non-drug interventions within real healthcare systems. The CDC has centers of excellence working to spread best practices. There's the K8-year model, used in primary care to help identify cognitive issues early using existing staff. And the Care Ecosystem Program, a telehealth-based team approach, has actually shown it can reduce hospitalizations and cut costs.
So better integration is achievable and makes a difference.
Definitely. These models show the way forward.
That's good to hear. Now, for our listeners who might be thinking about getting involved in the research side, maybe participating in a trial, how do they find legitimate ones? It can seem overwhelming.
It can. But participating is such a valuable contribution, and for some, it offers access to potential new therapies. The key is using trusted resources.
Like what?
Good starting points are trial finder tools on websites of reputable nonprofits, like the Bright Focus Foundation, for instance. Academic medical centers with Alzheimer's research programs are another key resource. Information directly from major universities or established pharmaceutical companies conducting trials is also generally reliable.
What about ads maybe seen online or social media? Should people be wary?
A bit more caution is needed there. In the U.S., all legitimate clinical trials have to be approved by an institutional review board, an IRB, that's an ethics committee. They review the study plan, the risks, and critically, they review recruitment materials to make sure they're accurate and not misleading. So look for mention of IRB approval or stick with the known institutions and organizations.
Good advice. And are there general rules about eligibility? Like, can you be in multiple trials?
Generally, no. For safety reasons and to ensure the data from the trial is clear, you can usually only be enrolled in one treatment trial at a time. Another important point right now. If someone is already taking one of the approved anti-amyloid drugs, like lecanemab,
Right.
they typically can't enroll in a trial for a new experimental drug.
Why is that?
Researchers need to see how the new drug works on its own. First, its safety, its effectiveness, without being complicated by the effects of another active drug. The ultimate goal is to test combinations, but you need to understand the pieces individually before you start combining them.
Makes sense. Are there trials specifically for people in that very early preclinical stage? The ones with biomarkers but maybe no real symptoms yet?
Yes, definitely. More and more trials are recruiting in this space. Often they recruit based on things like family history, or maybe someone has concerns about their memory, which leads to biomarker testing. And for many of these trials, the first step might just be a blood test to see if the necessary biomarkers are present. We mentioned studies like RETAIN or Trail Runner ALZ3 Laci. Those are examples recruiting in earlier stages, often using blood tests for initial screening.
And what about early onset Alzheimer's, diagnosed before 65?
Trials exist for early onset too, though perhaps fewer in number. The best route there is usually connecting with major academic medical centers, as they often have specialized programs focused on early onset or genetic forms of the disease.
Okay, so wrapping this up, we've covered the huge scale of Alzheimer's, the really exciting science and diagnosis and treatment, these non-drug approaches like light therapy, and efforts to improve care. But challenges definitely remain.
Oh, absolutely. The sources make that clear. We still need to get better at selecting the right patients for the right treatments, managing side effects effectively, ensuring everyone has fair access to diagnosis and care, regardless of background or location, and tackling those workforce shortages is critical. Continued investment and research across the board are just essential.
But despite all that, the overall feeling from the 2025 landscape seems to be genuinely hopeful. More so than maybe a decade ago.
I think that's fair to say. The progress is tangible now. We can identify the disease earlier, we have the first therapies that actually slow progression, and we're exploring really innovative, non-invasive approaches too. There are concrete advancements giving real reasons for hope to millions affected by this disease. Thinking back to what we discussed about subjective cognitive decline.
Yeah, that feeling something's off.
Right, that personal sense that your memory isn't quite right, even if the tests are still okay. We know can be an early warning sign for some people. So here's maybe a provocative thought for you, the listener, to mull over. How much weight should we give our own intuition about our health? That subtle feeling you might dismiss. Could it actually be a valuable signal? Perhaps prompting a conversation with your doctor, connecting you potentially to the very advancements in early detection we've been talking about today. It's worth considering.
As always, these presentations are for information only. Any medical issues or questions you have should be presented to a trusted medical professional. And finally, if you found this video helpful, please give it a thumbs up, share it with friends and family, and subscribe for more health insights. We'll see you next time.